Okay. Can you move? I think so. Move towards my boys.
Hey everyone, in today's video we're going to be going over the basics of individual first aid kits and their usage. Before we begin, I take no liability for your actions taken. This video is not meant to be a substitute for real medical training. This video is just meant to familiarize you with the concept of an IFAK. I always recommend that you go out and get training, whether that's CPR, Stop the Bleed course, Combat Lifesaver course, or any first responder medical training from a qualified professional and get your certifications in place. And always, in regards to anything medical, you want to default to the pros in the field and not try and make your own things up as you go along. So we're going to be going over two different things. The first is care under fire, and the second is going to be the march algorithm later on. But for right now, we're going to be focusing on care under fire. And a lot of what you saw in the beginning of this video is going to be considered care under fire. That's going to include the best medicine on the battlefield, which is fire superiority. Once you maintain that and eliminate or suppress the threat that initially caused your casualty in the first place, then you can move on to securing the area and assessing and treating your casualties. So as you saw in the first, one of the first things that we do is we initiate fire superiority. We take cover, we assess the possible casualties in the area. We see if they can self-treat, which means they can apply a tourniquet if it's needed to do so, or if it's safe for us to move them from open to a covered position, or whether or not they should be moving themselves if they're able to do so. So as you can see in the beginning, we maintain fire superiority. We instruct the casualty to self-treat, or we instruct the casualty to move towards the sound of our voice, towards cover. Or if they're completely unconscious and we need to fight past and into a target, like we're entering a house, we can step over our casualty, rolling them onto their stomach into a recovery position so they don't choke on their own blood or their vomit or their own tongue. So they can maintain an open airway until we can eliminate the threat in the area and come back and actually assess and treat them. So when you're determining whether it's or not it's safe for you to go and recover your casualty from their open position, you need to first maintain fire superiority. You do that by instructing your teammates to maintain a 360 watch around you, especially when you do get to the assessment and the treating portion of your casualty. So earlier we dragged him behind cover. Let's just pretend that he's still in cover, and we're getting the assessment portion of this. And this is where the march algorithm is going to come into place, and we actually start treating our casualty. So right now, if we have the teammates to show, we would have 360 security maintained on our casualty so that any other threats don't pop up in the area. So once we've secured the area and we've recovered our casualty to a safer position, we can begin assessing and treating our casualty. So we're going to begin on march, and before we begin on march, I would recommend that you go out and get what's called a march card, which gives you the algorithm on a card. In a stressful situation, you might not be able to go through all the steps in your head right off the top of your head. You might have to just have a visual guide to step you through the process so that you're not overlooking anything or you're not forgetting anything important. So the first letter in the march algorithm is of course M. M stands for massive hemorrhage. So when we first come up on our casualty, the first thing that's going to kill them is massive hemorrhage. If we don't get that under control and stop the bleeding, they're going to exannuate on the field right in front of you. Yeah, I'm gonna do. Isn't that like bleeding out?
Oh, no, I don't know. That's a pretty good word. I never knew that.
So the first letter in the march algorithm is M, and that stands for massive hemorrhage. What you're going to be doing in this portion of the algorithm is stopping the bleed. So if you go ahead and take stop the bleed course, this is going to apply to all that. One of the first things that you do when you're coming up on your casualty and assessing is you're looking for blood. So you're going to be going over and doing your checks, feeling for blood. You know, you're, okay, I found blood right here. So one of the first things that I can do is if I find blood, you know, pooling, massive amount of blood, what I'm going to want to do if it's on an extremity is I'm going to want to use a tourniquet. So one of the first things I can do in an emergency situation to get this under control is I can locate my casualty's tourniquet. Whenever you come upon a casualty and they have their own IFAC, you should be using their IFAC on them. Typically when the soldier is carrying an IFAC, it's for that individual. It's not necessarily for you to treat other people. However, in an emergency situation where you may have a casualty and they don't have theirs, of course, don't let someone die in front of you and bleed out in front of you if you can help it. So one of the first things I can do is I can identify, okay, my casualty has a tourniquet right here. I can take that off, get this around the leg. With the tourniquet, you want to get as high and tight as you can. It doesn't matter where the injury is on the leg. Let's say he shot somewhere around here, or he shot somewhere around here. Typical doctrine says that you want to get as high and tight on the extremity as possible. So if you're on the leg, you want to come up into the groin area. If you're on the arm, you want to come up all the way up into the armpit area as high as you can. So with the tourniquet, you already have it set and prepped so that you have it ready to go. That means that your tourniquet is going to have your windlass in place, loosened up, with this Velcro taped over to the side so that it's not in the way of your windlass. And when you open it up, it should be looped through so that you can get a loop through, and then go ahead and tighten it over. So this was already prepped. I like to keep a Sharpie tied up in there so that I can record the time when I put the tourniquet on my casualty. A lot of modern tourniquets have a place on the Velcro so that you can enter the time on it. If they don't have that, you can either enter the time right next to where the injury is if you expose the skin, or you can write it right on the forehead. If there's multiple ones, you can always kind of annotate right next to the time. This is the time that the leg went on, this is the time that the right arm went on, so on and so forth. So you come here, you get the Velcro in place. Go ahead and make sure that's about 2 fingers fitting comfortably in there. You're going to start twisting your windlass 2 to 3 times. It should really cut off the circulation. And then you take the Velcro and go over the top of the windlass, secure it in place. Take your Sharpie. If I have this exposed skin, and take the time on the forehead. So I'm going to take this off him so we're not killing him while we're doing this. once the tourniquet is in place, you want to make sure that you leave it in place for professionals to remove. If you have a tourniquet in place and it's not working properly and the blood flow hasn't slowed down at all, you can always take a second one, butt it up right next to it, and tighten that one down a bit more. And then you just leave both in place. Let the professionals handle it later on. And if you apply that at a later time, you annotate that, of course, as well. So during this portion, you want a tourniquet, you want a Sharpie, and you want a good wristwatch so you can go ahead and get the time real quick. So I'm just going to leave this in place loose on them. Then what we're going to do next is, once we've gotten the absolute emergency bleeding out scenario under control, is we want to locate his eye pack. So his eye pack is on his back. What we want to do is we want to pull that out from underneath him. And the thing that you want to do with your eye pack, not everyone is going to be trained to use all these things. But just because you are not trained on it doesn't mean that someone else in your team isn't trained on it. So, keep in mind, this is to be used on you. So if you do have someone that knows how to use it come upon you, provide them the tools in a very organized and easy to access fashion, as easy as you can, so that even if they're not familiar with you, they can figure it out and figure out where things are at. You want your IFAC marked clearly so that your first responder can find it and get to it. Now, if you are in a team, you want to default to the one with the most medical training in your team. So when you're going through your IFAC and you're all setting them up, you want to standardize them to the standards of your highest trained medical professional. So if he wants this type of tape, or he wants, or they want, some type of gauze or anything like that, go ahead and do it and set it up exactly how they want it, so that when they're saving your life, it's as easy as possible for them. So we're still in the M portion of the March algorithm. That's massive hemorrhage. So let's say that he's got this extremity wound. We've already tourniqueted it. It's slowed down. What we want to do next is we want to have a few things. So wherever there is a bleed, and we have identified there's a bleed somewhere in this area, it's pretty bad. I didn't have time to put on my gloves right at first. I was just trying to get that tourniquet on as quickly as possible. Go ahead and take the gloves out of their IFAC. If you feel like this is under control enough, you can go and start searching for other bleeds on the back. Start feeling around, checking your hands. No blood anywhere else. Okay, so this is the only place we've got bleed. So we got our trauma shears. What you're going to want to do is you're going to want to expose the wound, because if we're going to be treating this wound and trying to either pack it or wrap it and cover it, we're going to need to expose the hose from it. So I'm not going to cut his jeans right now, but what you do is you just come up here, careful not to cut your patient, go ahead and cut those jeans off and expose wherever the wound is. So let's say we've exposed the wound, we've identified that, it has slowed down, but what we want to do is cover it. If it's deep enough, we may have to go ahead and pack it with some wound packing gauze. If not, we can also use hemostatic gauze, or just the traditional H&H compressed gauze. So let's say there's a wound right here, you take your wound packing gauze and it's real deep. You want to go ahead and pack it. You're going to start feeding this out of this and pressing it down into the wound itself, packing it in as tightly as you can, searching for the place where the blood is coming out. And you need to get it right on there. You need to keep on packing it until you can get that specific area where the blood is pooling out of cover. Okay, so if you did pack it, then what you want to do after that is you want to start wrapping it as best you can with your compressed gauze. Go ahead and get compressed gauze around there, and then you want to take some of your tape it in place, and then keep an eye on it visually to make sure that there's no blood pooling through your bandages. If there is, you may not have done it right. You may have to take it out and find some fresh gauze, maybe out of your own kit, maybe out of another person's kit, and repack it and recover it. I'm sorry. And if it really is that bad, then chances are, like I said before, your tourniquet isn't doing its job, and you may have to do a second tourniquet right underneath it first. There are also emergency trauma bandages, which make the process of using compressed gauze and wrapping and then taping in place a lot easier. What this does is it's a pad and kind of like an ace bandage all in one that you can kind of double over itself and put pressure on the wound. So this will also apply pressure onto the wound as well. So that's another option. Not everyone carries it, but I suggest you do in your main eye pack, as well as your wound packing gauze and your H&H gauze. So another part of this is, if you noticed when in the first part of the video, when I first came up on my casualty, let's say I identified a massive bleed in the leg, there's blood all over here pooling. I came down with my shin right across the top of his leg in order to start slowing down the flow of blood. I can put pressure on whatever artery that is there, I can't remember the name of it, and start slipping on his tourniquet so that it slows that much more bleeding down as I'm getting it in place. Because every couple seconds of you losing blood that fast is a massive amount of blood. So you want to get that under control as quickly as possible. Let's say you're fumbling around and trying to find your tourniquet, or you're fumbling around trying to get it on. At least you have pressure on there and it's starting to slow down the flow of blood. So that's basically it for stopping the bleed. Now, if there are other, superficial wounds, not every wound, not every bleeding wound needs to be treated like this. There's a lot of injuries that maybe, they look bad, but they're not actually pumping or squirting out, and you're not going to have to worry about them. You can leave those till later. Let's say if he has a bunch of road rash right here, it's just kind of like oozing and it's real nasty. I don't have to treat that right now. What we're trying to establish is stopping the massive bleeding, and now we're going to move on to the A portion of the March algorithm, which is for airways. So with airway management, what we're going to want to do is we're going to want to determine whether or not our casualty is conscious and able to breathe on his own. So let's assume that our casualty isn't conscious. So I'm saying, hey buddy, wake up, I'm not getting anything, nothing, he's unconscious, he's out. Now I'm going to then make sure that he is breathing. How we're going to do that is we can look, listen, and feel for the rise and fall of the chest, the breath, listen for it. Okay, he's breathing on his own. Does it look like he's labored in his breathing? Or if he isn't breathing, what we're going to want to do is we're going to want to take some interventions. And what we're going to do with that is we're going to open his airway. So the first thing that we want to do is we want to tilt his chin back, so that we can open his airway. We want to check for any foreign matter. Is he choking on his tongue? Is there something in his mouth that's preventing him from breathing? Move him to the side, scoop it out if there is. If there's a lot of foreign material in there, let's say he threw up or there's a bunch of blood flowing in there, you can put him on his side in the recovery position if he is breathing on his own. But if he isn't, okay, we've opened the airway, we've made sure it's clear, there's nothing there. What we want to do is we want to come and get our nasopharyngeal airway. What this is going to do is it's going to create a clear airway in through his nasal passage, so that air is able to go in and out unobstructed. So typically, these are packed with a little tube of lube. If you don't have that, you can spit on, do whatever you need to do. So this has a bevel to it. Sorry, we're a little far away. So this has a bevel. And what you want to do is you want to make sure that the bevel is flat against the inside of the nose. So the septum, the little thing in the middle, you want to make sure that bevel is pointing towards it, okay? And then you're just going to slip it all the way down until the trumpet portion of it is sticking just outside the nose. So let's say we got this in there, okay, it's in place. I can feel, I can listen, I can feel that air is coming through it. What we want to do then is we want to take a small piece of tape, tape it in place onto his nose so that it's not going to get jostled around or moved out of place. So once we've established that that intervention did work, we can move on because we have established his breathing. Now even when we do establish his breathing, that doesn't mean that he's completely in the clear yet. There could be still respiratory issues coming up. So if he is conscious and he's able to tell you, I can't breathe like this, or whatever else, get him into a position that he's comfortable enough that he can breathe, given that there's nothing else obvious that's going to need attention or is going to hurt him further if he does get into that position. So if he has a big, massive sucking chest wound, you can't even worry about him right now saying that. You need to address that. And all the while through all this, you have to keep on talking to your patient. If you know his name, start saying his name. Wake up, you know, stay with me. How are you doing? You're going to be okay. Whatever it is, just keep talking. Try and keep their brain going a little bit. Try and keep them conscious if you can. Alright, so we're moving on to the R portion of the March algorithm. The R portion stands for respirations. So like I said, if he's still having breathing difficulties, we've established a clear airway, but he's still having breathing difficulties. That could be a sign that there is a sucking chest wound. What that means is that there's a hole in the chest somewhere, and there's air, or there's a hole in the lung, there's a hole in the chest, there's air leaking out from the lung into the chest cavity, and it's compressing your lung, collapsing it. So what we have to do is we have to stop any outside pressure by sealing the wound with something like a chest seal or any other occlusive dressing. Let's say that's the packaging from your trauma wound dressing and your tape around the outside, just anything that isn't a breathable material that will allow air to go through. So what we should have done in the portion where we're assessing our casualty, we've already got the tourniquet in place, we've got the massive bleeding under control, we've got an airway established. What we need to do is we need to take away any weapons and secure them. You know, you don't know the status of his weapon when he went down. It could be off safe, you could have one in the chamber, whatever, what have you. Go ahead and secure all that, make sure that everything is safe. Take weapons away, redistribute them to allies. Go ahead and take off any equipment that you can so that we can better assess this patient. So if he has a chest rig on or a plate carrier, what we're going to do is just unclip that, flip it over the back. You can leave it up underneath him for now, as long as it's off his chest and we can work in this area. So he is still having breathing difficulties. We have established the airway. There is air coming through there, but he's having breathing difficulties. So what we need to do now is we need to expose the area. You know, let's say I identified blood coming through here, pulling through here. I'm like, okay, there's a hole right here. He was shot in the chest. What I'm going to want to do is I'm going to want to reach for my chest seals. So typically they come in a 2-pack. I use hyphen chest seals. So we expose the wound as much as we can. Cut this off, out of the way. Alright. So there's this massive hole right here. We open one set of our chest seal, slap it down right on there. If there's a lot of blood, what I like to use is these gauze sponges or ABD pads, just some type of like flat absorbent material that I can kind of wipe away. It's a sterile dressing, you know, I'm not gonna have to worry about any of that, but I can wipe away the area so that there's not excessive moisture when I'm trying to get this chest seal to stick in place. So I wipe it away with the gauze sponge, and I can go ahead and put the chest seal in place. Now what I want to do is I want to grab my patient, roll them onto the back, check their back. Is there an exit wound? There probably is. I wipe away as much as I can. I come here with the other chest seal, slap it in place, make sure it's really on there, and then roll my patient back down. All the while I'm checking to make sure that there's no other crazy injuries on his back or anything else that needs my attention at the same time. So, I've got teammates doing 360 security. What I need to focus on is my patient. Now let's say that our patient, after we have sealed his chest cavity, that he's still having breathing difficulties. This is more of an advanced technique, but if you know how to do it, you know how to do it. And even if you don't know how to do it, go ahead and carry a needle, a 14 gauge decomp needle anyway, for what's called detention pneumothorax, which is what I described earlier, where there's air leaking inside the chest cavity and putting pressure on the lungs. So what we're going to want to do is we're going to want to stop air from going into the original wound, and we're going to allow a passage for the air to come out using this 14 gauge needle in through his chest, allowing it to let the pressure off of his lung. And it's not going to allow any more air to come into it. So with your 14 gauge needle, there are a couple different locations depending on your patient. Let's say the wound is in a spot up here where you won't be able to get the ideal location to stick them, and you may have to go into the side. So what you want to do is you want to identify your second and third intercostal space in between your ribs. So you'll start from your clavicle, you'll go down 1 and 2, and in between the second and third is where you want to stick your needle, right in line with the nipple line and just in between the second and third. So what you're going to do is you're going to go ahead and take the cap off this, get the needle prepped, and you're going to kind of ride over the second rib bone and into the third. So you'll kind of rotate it in a little bit, I suppose. So you go ahead and you identify that spot, go ahead and stick them, get it in there, you take the needle out, you leave the catheter in place, and then you go ahead and take a small piece of tape, you go ahead and tape that in place. Now what you want to do is you want to look, listen, and feel again for any air escaping from that catheter that you left in his chest. So you should be able to either feel or hear or see maybe fluid coming out of there. There is a chance that your needle does get fogged. What you can do is slightly turn it a little bit in order to attempt to unclog it. If you can't, you may have to do a second one, but typically, you know, it's a much more dire circumstance if that's the case. So let's just assume that, yes, it did work. We don't have to go onto the side in between between the fifth intercostal space on the side. So we don't have to worry about that. I'm just trying to get the basic out there, and the basic area that you're going to go is in between the second and third in line with the nipple, or just about, depending on if the patient's, you know, got tips or whatever. So we're going to keep an eye on the interventions that we cause. We're going to look, listen, and feel to see if his breathing does improve. If it does, we can go ahead and move on from that. If he's not, like I said, it might be fogged. You might have to do a quarter turn. If there is no air escaping from it, you might not be in the right place. You might not have done it right. You might have to do a second one. But right now, you know, you might have to burp the chest seal, so just coming back and letting a little bit of air escape. and then resealing it down again. If you don't have to do any of that, we can move on from the respirations portion of this and move on. So we've got that all in place, we've checked that it's nice and secure, and now we can move on to the C portion. So the C portion stands for circulation, or checking for signs of shock. So under this, I don't typically carry IV kits, but if you need to get the circulation going, if he's hypovolemic, you might have to introduce extra fluids into him. So go ahead and get the IV started, get the bag in him, get it started up, and now you're going to want to assess for signs of shock. So let's say he's still unconscious, but he's breathing, the bleeding stopped, his breathing is improved, so we don't really have to worry about that. Of course, we're still talking to him, trying to get him awake, you know, everything else. And at this time, another thing of circulation, after we do our checks, we go over and we check all our interventions, we make sure that the tourniquet's still in place, make sure that there's no pooling blood in the dressings that we put on, make sure that the chest seals are good in place, check the one on the front. We will be moving him onto litter soon, so we'll check the back chest seal when we do go to move him onto litter, so we're not moving him excessively. Check to see that his nasopharyngeal is still in place, still working. Check that his needle decomp is still in place, that it's still working. We're all good. We did all our checks, and we've established fluids and circulation. We've checked for shock. You know, if he is conscious and he is in shock, we're going to have to do a few things like get him warm. So hopefully someone in your team has a litter prepared. So what we're going to do is we're going to prep this. We'll go ahead and throw the litter down next to him. All right. What you want to do is remove as much equipment as possible. Oh, you're not. You're supposed to be unconscious. So the C and the H for me kind of meld into each other, because part of the H, part of the algorithm is hypovolemia, which we've already addressed with our intervention of IV fluids, and we've gone through all our checks and everything else. And the next part is hypothermia and head injury. So the head injury we can address once we address the possibility of hypothermia. So what we've done is we've set up our litter right next to our patient, and what we're going to do is we're going to do two things right now. Okay, so we're going to flip the patient, we're going to recheck the intervention of the chest seal in the back, and then we're going to move this litter up underneath him and lay him back down on top of him. So we go just like this. Chest seal is good, it's in place, doing what it's supposed to do. Then we get the patient to roll back onto the litter, pull him up, move him into the center of it as best we can. Then what we're going to want to do is we're going to take our mylar blanket or survival blanket, whatever you want to call it. We want to spread this out over the patient. Okay, we'll have his arms at his sides so that they're not in the way. And then we're going to want to go ahead and tuck him into a big burrito. Okay, so that we can keep his body heat inside. If he has wet clothes on, you may want to cut those off of him so that it's easier for him to get his body temperature back without having to drop the or increase the temperature of the liquids that are, you know, all in his clothes, all over him. So go ahead and take off any wet clothes, go ahead and get him into the burrito, and as you're doing that, of course, you're rechecking interventions, and you're checking to see if there are any other small wounds. Like we said before, maybe there's a bunch of road rash right here. Now's the time where we can say, okay, I've got, you know, some gauze here, and I got some tape. I'm going to cover this area. It's not a life-threatening wound, but it's going to maybe save him from infection or something like that. So we're going to treat that as best we can. Any other little cuts and bruises and shit like that, we're going to be treating it this time and exposing as necessary. Now we're going to be moving on to the head injury portion. Let's say he's regained consciousness. He's like, oh fuck, what the hell's going on? And he's awake again. Now I'm going to be kind of looking at his eyes. Are his eyes focused? Are his pupils dilated? Or is there anything going crazy on with his eyes? Does he have raccoon eyes, big bruising underneath the eyes? Does he have anything going on like that? You know, this portion, you're basically just checking to see the overall health of your patient after all your interventions that are going to keep his life going, because you're maintaining his blood, his circulation, you're maintaining his breathing. Now everything after that is going to be, you know, low intensity. You know, I don't know how to put that. So let's say he's got a head injury. What we're going to do now is we're going to really want to keep him conscious. We know he's got a head injury, so we're really going to be talking to him now. You know, keep him awake, because the last thing you want to do is have someone like fucking slip into a coma because they had a head injury and you let them, you know, take a nap. So you want to keep them up. You want to make sure that you're rechecking all the interventions. What you're going to want to do now is that you should have already had a teammate that was maybe on 360 security or he was free from it. They should have already started calling in on the 9-line medevac so that they can get your casualty evacuated, you can get to a higher care facility and get that taken care of. So at this time, we've done all our interventions, we've got our patient stabilized, we're waiting for the evac to show up, whether that's an ambulance or a helicopter or whatever the hell you got access to. That's what we're waiting on now. And in the meantime, what we're going to do and what I recommend you carry is what's called the TCCC card. It's a tactical combat casualty card. And what that's going to do for the people that come to pick your guy up is that's going to help them assess and know what exactly happened. So on these TCCC cards, it's going to say, okay, you know, what happened, when did it happen, how did it happen, you know, was it an RPG, was it a gunshot wound, was it an IED, was it this, was it that? So you're going to go and fill all that out. You're going to fill out all the interventions you did. I applied a tourniquet at 10:45 to the right leg. I applied the nasopharyngeal. I applied a chest seal to the front and back. There's a massive sucking chest wound, you know, here or there. I applied the decomp needle, and everything else that you did, you're going to want to annotate on that TCCC card. You're going to want to secure it to your patient after you have them all wrapped up in the burrito and they're ready to be moved. And you want to just slap that label on the burrito for the people that are going to be coming and picking it up to know what's going on with them without you having to sit there and, you know, explain the whole wild story to them. So at this time, let's say that the cavalry has showed up and they're ready to take our guy. We've got him all wrapped up. We get our 4 teammates. We have the area secure. What we want to do is do a team lift. So we got 2 people right here, 2 people right here. We each have 2 handles. We want to pick them up as evenly as possible and transport him to the back of the car or inside the helicopter or wherever we're going to get him onto. So we go ahead and do that. We get him transported safely and gently to wherever he needs to go, and then it's out of your hands. Now, before we ship him off, if there is the option of combat pill pack, at the time that you've already gone through all your interventions, that's the time that you would administer the combat pill pack. And of course, at that time, you should have already removed their weapons and everything else, but you definitely want to remove it because they're going to be sitting there kind of high. And you don't want them to have access to their own weapons. You never know what is going through their head when they're in this state. So just keep that in mind. If you do have access to that before, you know, while you're waiting on your evac to show up and you got your patient all ready and packed up to go, that's the time that you would administer that. So that's it for this video. I tried to go over everything and all the basics that's included in an IFAC. I may have not covered everything as clearly or as completely as I should have. But like I said before, this is not a substitute for real medical training. It's just to get you familiar with what items you should be carrying in your IFAK and why you should be carrying them. Whether you know how to use them or not, it's for the first responder that finds you in order to use them on you. So you need to find a standard and you need to stick with it, and you always need to carry those things. You don't need to be making up your own IFAK contents or trying to reinvent the wheel with this. You need to just stick to a standard and stay with it and default to the professionals in the field. So I hope that was informative. I hope you learned something from this. If you did, please check out the next video where I'm going to be going over my pistol setup and how I believe pistols should be set up. Thanks for watching.
I'll shake my boots. I was like, yeah.
Our patient, everyone. He's okay.
Okay.